As they're benign tumors, even though they do not progress to malignancy, there have been a genetic basis for this progression. They're usually associated with a genetic mutations with the gene MET12. And this gene actually encodes a component of RNA polymerase transcription complex, and it has been shown that in 70% of the leiomyomas, this exact gene has been mutated. So usually those tumors are multiple in the myometrium. They can actually invade the surrounding organs, the ones that are close nearby to the myometrium. For example, in the peritoneum, they can invade, and also they can develop a blood supply. So this is called the parasitic leiomyomas. Apart from that, it's usually benign. It can cause the increased bleeding more than 7 days during the menstrual cycle. So that's all about the leiomyoma. Now let's get to the more complex part. This is the pathophysiology of the polycystic ovary syndrome. So you see, this is the pituitary gland, which secretes LH and FSH. Somehow it happens like this, that LH is 3 times higher than FSH. This one, which causes theca cells to produce testosterone, right? LH stimulates theca cells, which convert cholesterol into testosterone, and then usually this testosterone is traveled to the granulosa cells. Granulosa cells are stimulated by FSH to convert testosterone into estrogen. But unfortunately, due to the lack of FSH, there's 3 times more testosterone production than conversion of testosterone to estrogen, which causes the classical symptoms of the polycystic ovary syndrome. Okay. Now let's talk about the ovarian tumors. So there's 3 types of ovarian tumors. The ones that are epithelial tumors, those are the most common tumors. I think like 90% of cases there are epithelial tumors. They're sometimes positive for carcinoma antigen 125, but not always. Always, because some other tumors as well are positive for this biomarker. Epithelial tumors include adenocarcinoma, which is the most common. It is divided into serous part and mucinous. We have second one, which is a Brenner's tumor, and we have endometrioid tumor as well. We had endometrioid tumor in the endometrial as well, as you remember, the endometrial carcinoma. But in ovaries, we have endometrioid tumor as well. This was epithelial tumors, the most common. The second type of tumors are germ cell tumors. Those include choriocarcinoma, increased HCG, human chorionic gonadotropin. We have dysgerminoma. This also expresses the human something. And the third one is teratoma, which is more frequent than those two. There are 2 types, mature and immature teratomas, and the third one is sex cord or stromal tumors. Those include Sertoli Leydig cell tumors, which secrete testosterone, It causes virilization, which means the masculinization of the woman, increased body hair, voice change, acne, the problems with the menstrual cycle. The second type of sex cord tumors are granulosa cell tumors. As you remember, granulosa cells secrete estrogen. So here we have amenorrhea, oligomenorrhea. We have irregular uterine bleeding, endometrial hyperplasia, with or without subsequent carcinoma. So those symptoms are due to excess estrogen. And the last sex cord stromal tumor is Tacoma fibroma, which results in pleural and peritoneal effusions. Right. Okay, let's first discuss the most common type, which is epithelial tumor. The least common are sex cord and stromal tumors, but those are kind of most interesting ones due to their secretion of hormones. So let's start with the cystadenocarcinomas. So we have two types, the serous cystadenocarcinoma, which is more malignant, and we have the second one, which is mucinous cystadenocarcinoma. This is less malignant. So serous one is more common ovarian tumor. It usually occurs in postmenopausal women. So there's increased serous fluid production inside of the cyst itself, and the symptoms associated with it is weight loss, abdominal mass, and complications including ascites, ovarian torsion, which is just imagine those are ovaries, right? The fallopian tubes. Torsion is when there's a adenocarcinoma here, and those ovaries somehow twist around it. So it's like they're twisted like this, and there's cyst in here. So I don't know how to explain, but it gets twisted around the cyst itself, which is very painful. Ovarian torsion morphology is it's adenocarcinoma. And now morphological features actually include the ones I'm going to show it, I'm gonna see right now. Okay, yeah, let's just differentiate those two. So serous cystadenocarcinoma are two types. One is a low-grade tumor, which is more benign, and we have high-grade tumor, which is more malignant. So low-grade is associated with genetic basis mutation of the CRAS proto-oncogene, and the second one is associated the high grade is associated with the mutation of TP53. So when there's mutation of TP53, it usually most likely leads to malignancy. So that's the problem in here. So usually this adenocarcinoma is unilateral here, but it can, in 25%, it can be bilateral in both ovaries. There's also interesting thing that there are psammoma bodies. So serous cystadenocarcinoma is associated morphologically with psammoma bodies, which are concentrically laminated calcified concentrations, and those can be seen morphologically. It's highly likely that those serous cystadenocarcinomas can be malignant. There are benign ones and also borderline ones that can either be malignant or benign. But usually it's those borderline ones are 100% associated with the 100% survival rate. Also, the malignant ones are difficult to treat if the it's a long-standing carcinoma. So usually, if we discover it in early stages, the probability is high for it to be treatable. So mucinous tumors greatly resemble ones of the serous ones, but instead they secrete mucinous fluid, and they're mostly benign compared to the serous ones, right? The same prevalence for the women of postmenopausal age. There's increased mucus production inside those cysts, and it can sit to the peritoneal organs, and it can actually result in a ascites and a condition known as pseudomyxoma peritonei. This is when the seeding happens to the peritoneal cavity, and there's a lot of mucus production. So it's like due to those cyst adenocarcinomas, mucus production is so increased in the peritoneum that the whole peritoneum can be filled with the mucus. Now, it's associated, and there's a very high resemblance with the Krukenberg tumor, which is a metastatic GI tumor which can spread to the ovaries, and it's mucinous tumor as well. So Krukenberg is like exactly the same as the mucinous cyst adenocarcinoma, but in this case, in Krukenberg's tumor, we have bilateral cysts in the ovaries, but in case of the mucinous cyst adenocarcinoma, we have always unilateral cysts. So we can differentiate by this. Symptoms associated with the mucinous cyst adenocarcinoma are weight loss, as with other cancer conditions, abdominal mass due to the cysts. Complications include ascites, ovarian torsion as well. So both cysts are associated with the with the turning of the ovaries around the cysts. And morphologically, it's adenocarcinoma. It secretes mucus, and we have multilocular cysts. So that was two most common epithelial type of tumors. Now let's talk about endometrioid tumors. Endometrioid tumor resembles one that was endometrioid carcinoma. There's also a genetic association with the pt.3 gene. Mutation of this gene is associated with the endometrioid tumor. It's also associated with endometriosis, and less than 30% also have endometrial carcinoma, and it's mostly malignant. So it can be both endometrial carcinoma and the endometrioid tumor of the ovary as well. So Brenner tumor is kind of rare kind of tumor, which is characterized by transitional epithelium tumor, which consists of transitional epithelium in the ovaries. Transitional epithelium is the one that is in our urinary bladder. So that's all about it. I'm not sure if it's very malignant or benign. I don't remember, actually. So the most common germ cell tumor includes teratomas. We have two types of teratomas. We have mature teratomas, which are well differentiated. So you remember, teratomas are tumors that originated from all three types of germ cell layers. Those are mesoderm, ectoderm, and endoderm. So mature teratomas are well differentiated, and they're benign. They're characteristic for the older women, usually older women, but teratomas are associated with their disease stages. The prevalence is usually in 2 decades, like 20s are most common for teratomas, right? Compared to other other genitourinary problems of the women. The most common age is early 20s. if it occurs in the earlier ages, like 18, 19, it's more likely that it's going to be more malignant. In mature teratomas, usually ages up to 30. Older women, but usually they're not very old, they're still in their 20s and 30s. Mature teratomas are benign tissues derived from all three germ layers. Those are usually, like, you can see like teeth, hair. It can also contain like nerve tissue or other types of tissues, like for example like lung tissues or something like this. Rare complication of rare paraneoplastic syndrome is the limbic encephalitis due to mature nerve tissue inside of those teratomas that can cause the limbic encephalitis, but luckily those teratomas can be removed, and this will consequently stop this paraneoplastic syndrome, which is limbic encephalitis. Now, there's a special type of teratoma known as truma ovari, which closely resembles thyroid gland, and it can cause the hyperparathyroidism and consequently thyrotoxicosis. Okay, that's about the mature teratoma. Now, immature teratoma, which is malignant, usually the medial age of prevalence is 18 years. So it's very young women, right? Nearly the adolescence. So it's poorly differentiated. There can be some parts of the hair or something, but it's not very well visible. There's poorly differentiated tissue, and the same way tissues derived from all three germ layers. Now, two other types of germ cell tumors we have. One is dysgerminoma, which is malignant. This is similar to testicular seminoma, but in this case, it happens in women. In morphological images, we can see clear glycogen-laden cells, and there is a small amount produces human carcino HCG, human chorionic gonadotropin. Yes, that's it. But it's usually higher than the regular level of the human chorionic gonadotropin. So if the woman is pregnant and at the same time she has a dysgerminoma, the HCG levels would be higher than in the regular pregnancy. In case of choriocarcinoma, we have choriocarcinoma of the ovary. This is malignant as well. We have dysplasia of the cytotrophoblast and syncytiotrophoblast cells, leading to invasion and early hematogenous metastasis and lymphogenous metastasis as well. In this case, HCG is increased too much. Like HCG is like very much increased in this case. Okay, that was all about the ovarian tumors. Now let's talk about the gestational trophoblastic disease. So this is diseases of the pregnancy, I believe. Yeah, I don't remember this one, so I'm not going to talk about this. Let's talk about gestational hypertensive disease, which usually develops in third trimester, about 24th week. So those diseases include preeclampsia and eclampsia, which is actually not very uncommon. It's in 1 to 5% of first pregnancies for women pregnant over ages of 35. The preeclampsia is characterized. The main hypothesis and the basis of this disease is that there is some kind of problem with the chorionic villi. So there is a hypoperfusion of the placenta, which causes subsequent disease, which is characterized with preeclampsia. So due to hypoxia of the placenta, preeclampsia can develop. So this includes hypertension, which is probably malignant due to its problem with the end organ damage, such as firstly kidneys, causing proteinuria due to damage of basement membrane, and edema due to the loss of proteins. Complications include placental infarction due to insufficient blood flow and abruption of the placenta. Eclampsia is the same syndrome. Eclampsia is the same as preeclampsia, but with additional CNS effects. This probably happens due to hypertension as well and damage to the central nervous system. Complications include placental infarction and the same ones, insufficiency or abruption. And here we have breast cancer. I don't know breast cancer well as well, so I'm not going to talk about that. Thank you.